communicate directly with an older patient rather than asking others about her. That again, that goes back to just being respectful. Don't assume that they can't speak for themselves, they can't think logically. Always just talk to them like anybody else, and then go from there. Depending on your response, that will kind of guide the rest of your call and how you're going to handle this patient. See, scene size up and safety. Look inside and outside residence for clues to physical and mental abilities. So yeah, as you're walking into the patient's residence, you kind of get a pretty good idea of how this patient is living just by walking into the residence. How's the yard? Is it made? Is it not made? Are there just piles and piles of dishes on the sink that haven't been washed for weeks? Things like that that kind of tell you a little bit about the patient. Are they able to take care of themselves? How's their mental status? Things like that. Um, See, so condition of residence, half-eaten food, house dirty or clean, items left out that patient can trip on. So just to give you an idea of how the patient is doing. See, older people are twice as likely as younger people to use EMS. I would write this as a note only because I feel like I've seen this somewhere before, like on a test somewhere. So I'll give you guys 30 seconds or a minute. Just write that little note down right there. It'll help you out down the road, I'm pretty sure. Now, why they are twice as likely to call? Um, could be for one or two reasons. One is they're just really worried about if they feel any issues or they feel abnormal. The other one is sometimes older people sometimes don't have anybody to talk to, so they just become frequent callers just because they kind of need that attention. So they'll make up sometimes excuses, or maybe they'll even really feel like they are ill in one way or another. But those sometimes tend to be the patients that are alone and have nobody to come see them. But regardless of if that is the case or not, just remember to be respectful and kind because they still are patients. So that's really important. See, finding a radial pulse in an older patient is usually no different from finding a pulse in other patients. True. The one thing that you have to look out for, though, in your geriatric patients is having those abnormal heartbeats. Sometimes you'll encounter thready beats that are just really rapid, really thready. You can barely feel them. Other times you'll have an abnormal heart rate, but that's their normal. It'll be like a beat, beat, pause, beat, 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 pause, beat. That's one example of an abnormal beat that's their normal for that person, for that patient. So things like that, you will encounter those, but like any other patient, you just take it in the radial pulse. But just and the reason I'm saying that is because I wasn't told that when I went to EMT school, or nobody told me that. So the first time I encountered that, I was just confused because I couldn't understand why their heartbeat was so different. And then the more patients I got, the more I started realizing, oh, the geriatric population, like they just have different heart rates, and it's because of illnesses or medication they're taking, things like that. All right, so secondary assessments. See, take time needed to get full information. With geriatric patients, just understand that there's a good possibility that you're gonna take longer with this population than you would with any other population. Okay, because they are slower. They are reacting a little bit slower. Functions are starting to decline. So just give them time. See, find out whether patient is compliant with medical advice. So meaning, is this patient taking the medication that's prescribed to them by their physician, or are they not? Ask family members, other familiar with patient's conditions. Physical exam and get your baseline vitals, obviously. See, anything here that stands out? So pelvis and extremities. Hip and proximal femur commonly fractured in falls. So yes, this is very common. This is a very common fracture. It's gonna be a hip fracture, or really, It's the femur fracture, but the very top part of the femur. Weakening of bone results in injuries to wrist and proximal humerus. This right here, I would write down the very last part where it says pelvis and extremities, specifically where it says hip and proximal femur commonly fractured in fall for your geriatric population, the elderly population. So go ahead and write that down real quick. It's gonna serve you well down the road. All right. A shingles rash often appears as a narrow. So shingles is chickenpox. So it's I guess the chickenpox doesn't really go away. It stays dormant in the body, and sometimes when you're um in your older ages, it just comes back, but it comes back as shingles, and it looks like this. And it's usually it is on the torso, and it's explained as a belt-like band, just like it says here. It is blistery, no, but also you have to understand that just because you're not in the elderly population does not mean that you cannot get this. If one of these blisters do burst and comes on you, and gets in contact with your skin, you can get this and have a reaction yourself. Now, usually it is found on the torso, but not always. This could appear on any part of the body, but usually it is found in the section. And remember, if you see this, be very cautious because you can get it if the fluid gets on you. See pelvis and extremities, check extremities for edema and swelling. Again, those that would be an indication of heart failure, special pedoedema. Remember, pedoedema means fluid in the ankles. See, when significant, these can be signs of underlying heart, vascular, or liver disease. It's like we talked about. See, spine, very commonly injured in motor vehicle collisions. So the one thing about the elderly population is you have some people with the curvature in their back. Some people call it a hunchback, and also on top of that, these patients have sometimes have fragile skin. I mean, or thin skin, and can be broken easy. So with that in mind, you really want to make sure that if you're gonna put a geriatric person on a spine board, make sure that you absolutely do need to put him on the spine board because this patient is going to be very uncomfortable on that spine board. You're going to have to really apply a lot of cushion under the voids around the curvature to compensate for the curvature. On top of that, when the vertebrae are pressing down on the skin, there is a potential for that skin to break and cause more issues down the road. So that's why I'm saying be very cautious when thinking about putting a geriatric person on a spine board. Make sure you really have to do that if you're doing it. So you do best to keep vertebrae in line and reduce patient discomfort. See, reassessment, more common for older adults to show a slow, steady decline in condition. Again, that goes with compensation. They can't compensate as well, so you're not going to see that rise right before the decline. All right. You may be lured into false sense of security, and that false sense of security again comes from that patient gradually declining and not compensating, not going all the way up before they come all the way down, because that's when we see that crash. See, reassess at regular intervals. So every 15 minutes, if there's nothing wrong with them, if you think that they may have an issue or may crash, no more than 5 minutes in between your checkups or your reassessments. Yeah, and mental status, maintain open airway. See, talking with a patient during transport can be therapeutic for the patient and enlightening for the EMT. That's actually very true. one, the patient, usually, not always, sometimes you have those patients that just don't want to talk to you, and that's okay. But usually patients are pretty eager to talk to you if you're in the back of the rig with them. At the same time, they can teach you a lot. They really can if you just listen. All right, we're taking a little 10-minute break, guys. So I'll see you guys in 10 minutes. All right. So medication side effects and interactions. So drug-patient interaction can occur because of inability to clear medications from body as quickly as before. Drug-drug interaction, when two drugs interact in the body. That doesn't really affect your NREMT. See, older patients often take multiple medications. That is true. So if you go to a geriatric patients, um, it wouldn't be uncommon to see it like this, or actually see it a lot worse. Sometimes you'll go into a patient's house and you'll see a whole bunch of different pills in just one container. So that's just something to know. Shortness of breath. So can result from diseases that cause this symptom in younger patients, like asthma as a good example, pulmonary embolism. So they're just like any other patient. Shortness of breath. They're gonna have the same medical issue as a adult patient, a pediatric patient. The only big difference is the reaction to that illness is slower. The sensation is slower, and it's because of that decline in function. Elderly patients are more likely to have emphysema. Of course, that's because emphysema is one of those illnesses that occur over time, and usually it's because of exposure to environment or smoking, uh, or a combination of these diseases. See, chief complaint of patient experiencing a cardiac problem. So yes, a lot of your patients that are have angina, so chest pain because of a cardiac issue, they will also present with shortness of breath. That is true. So chest pain. So complaint of chest pain can indicate many conditions. Angina in itself, angina is just, that means pain from a cardiac. So the origin is cardiac. That's where the pain is coming from. Okay. Myocardial infarction is a heart attack. And so myocardial infarction, which is the exact same thing as a heart attack, means that you have a clot in one of the arteries, one of the vessels that feed the heart itself with blood. So if you have a clot there, you're gonna have a piece of a heart that's not getting oxygen. So pain will come from that. That pain is called angina. Okay. Pneumonia. If they have infection in the lungs, that does cause pain. Any infected part usually is painful. And aortic aneurysm. So an aneurysm, remember, an aneurysm means that there's a bulge coming out of one of the vessels in the body, and that's because a section of that vessel, the layers of that section have become so thin that they're bulging out from the pressure. Just like when a water hose, when you lose that top layer of water hose uh, skin, or whatever you want to call it, the interior part will bulge out when the water is rushing through it. It's the exact same concept. See, altered mental status. So these are all the reasons why your patient may be mentally altered. Adverse effects from medications. We kind of talked about that. Hypoglycemia means that they have low blood sugar, and again, you need oxygen and glucose to make ATP, right? To keep your body going. Your brain also needs this. So if there's low sugar in the system, your brain is not being fed good enough. A stroke, which means that there's a clot in the brain, so a section of the brain isn't gonna get blood. That's gonna cause your patient to be mentally altered. Sepsis means it's a system-wide infection. The infection spread and got throughout the entire vessels of the body, which falls under the same lines as generalized infection in bloodstream. Sepsis could be put right underneath that. Hypothermia, everything is slowing down because of cold temperature, which could also lead to a patient being mentally altered. and then pneumonia by itself. And the pneumonia, I would contribute pneumonia to your patient being mentally altered because of the fact that it's interfering with that gas exchange from the alveoli to the capillaries, the alveoli to the capillaries, that gas exchange. And it's because of the infection itself, but also from the fluid that's going to that area, which occurs with almost any infection. Fluid is attracted to that area. You have white blood cells that are going to rush to that area, and plasma. Abdominal pain and gastrointestinal bleeding, often a sign of serious conditions such as, and here's the list of them. So again, that aneurysm, abdominal aortic aneurysm against a bulge. That means that the biggest artery in your body has a bulge in it from that pressure. Bowel obstruction or blockage, of course, that would cause pain and could do other issues in there. And I think it's pronounced diverticulosis. That means that little sacs are forming in your large intestines. And I actually found a video on that, so I'm going to show it to